Have you ever wondered what keeps a doctor awake at night? What case haunts them years after they've closed the file and moved on to the next patient? For most physicians, there's always that one case that changes everything they thought they understood about medicine, about hope, and about the fragile line between life and death. My name is Dr. Sarah Chen, and I've been practicing oncology for 12 years at Cedar Valley Medical Center. In that time, I've treated thousands of patients, witnessed countless recoveries, and unfortunately said goodbye to far too many souls who fought battles they couldn't win. I thought I had seen everything the world of cancer could throw at me. I was wrong. The case I'm about to share with you took place during my 8th year of practice, on a cold February morning that started like any other. What unfolded over the following assumption I had about cancer weeks challenged every treatment, patient psychology, and the mysterious ways the human body responds to terminal illness. This isn't just a medical mystery. It's a story that will make you question everything you think you know about the nature of healing, the power of the mind over the body, and what happens when medical science encounters something it simply cannot explain. Before we begin, I want you to know that everything I'm about to tell you is documented in medical records, witnessed by multiple healthcare professionals, and remains one of the most perplexing cases in our hospital's history. The patient's name has been changed to protect privacy, but every other detail I share with you is exactly as it happened. Take a deep breath, because what you're about to hear will stay with you long after this video ends. And if you want to understand why I eventually left oncology to pursue research instead of direct patient care, you'll need to hear this story in its entirety. February 18th began at 6:30 in the morning with my usual rounds through the oncology ward. Cedar Valley Medical Center is a 400-bed facility that serves the entire northern region of our state, and our oncology department handles some of the most complex cancer cases in the area. I had been working there for 8 years and prided myself on maintaining hope while being realistic about prognoses. That morning, I was reviewing charts for my scheduled consultations when my colleague, Dr. Martinez, approached me with an unusual request. "Sarah, I need you to take. We'll look at something. I've got a new patient, 34-year-old female, and her scans are unlike anything I've seen in 20 years of practice." Dr. Martinez was not someone given to exaggeration. He was methodical, experienced, and had a reputation for handling the most challenging cases with calm precision. When he said something was unusual, it meant we were dealing with something truly extraordinary. The patient's name was Rebecca Thompson, though that's not her real name. She was an elementary school teacher from a small town about 2 hours from our medical center. Rebecca had been experiencing symptoms for approximately 6 months before seeking medical attention. Fatigue, weight loss, persistent cough, and episodes of severe abdominal pain that would come and go without warning. Her local physician had initially attributed her symptoms to stress and overwork, but when the pain became unbearable, she was referred for comprehensive testing. The results of those tests were what brought her to our attention. Rebecca had multiple primary cancers affecting different organ systems simultaneously: lung cancer, pancreatic cancer, liver cancer, and ovarian cancer, all diagnosed at the same time, all appearing to be separate primary tumors rather than metastases from a single source. In medical terminology, we call this synchronous multiple primary cancers, and it occurs in less than 1% of cancer patients. But Rebecca's case was even more unusual than that statistical rarity would suggest. I walked into examination room 3 that morning, expecting to meet a woman who would be understandably terrified, probably emotional, and certainly overwhelmed by her diagnosis. Instead, I found Rebecca sitting calmly in the chair next to the examination table, reading a book about meditation. She looked up when I entered and smiled with a warmth that seemed entirely inconsistent with someone who had just received a terminal cancer diagnosis. "Good morning," Dr. Martinez told Chen. DRD me you'd be joining my care team. I appreciate you taking the time to see me." Her voice was steady, her demeanor peaceful, and her eyes held a clarity that I found both comforting and deeply unsettling. Patients facing terminal diagnoses typically displayed anxiety, anger, bargaining, or depression. Rebecca displayed none of these expected emotional responses. "Rebecca, I've reviewed your test results, and I want to discuss your treatment options. But first, I need to understand how you're processing this information. Multiple cancer diagnoses can be overwhelming, and it's completely normal to feel scared or confused." She closed her book and looked directly at me. "Dr. Chen, I appreciate your concern, but I'm not scared. I know this sounds strange, but I've been expecting this diagnosis for months. Not the specific details, but I knew something significant was happening in my body. This response was unlike anything I had encountered in my years of practice." Patients don't typically expect terminal cancer diagnoses, and they certainly don't discuss them with the calm acceptance that Rebecca was displaying. I decided to proceed with the medical discussion while making mental notes about her unusual psychological presentation. "Rebecca, your scans show cancer in multiple organs. We're looking at Stage 4 lung adenocarcinoma, Stage 3 pancreatic ductal adenocarcinoma, Stage 4 hepatocellular carcinoma, and Stage 3 ovarian serous carcinoma. Each of these cancers appears to be a separate primary tumor, which means they developed independently rather than spreading from one original site. This is extremely rare, and it presents significant treatment challenges. Most patients would have interrupted me with questions, concerns, or emotional responses. Rebecca listened intently, nodding occasionally, as if I were explaining something she already understood. When I finished my explanation, she asked a question that caught me completely off guard. "Dr. Chen, in your experience, have you ever encountered patients whose cancer seemed to respond to factors other than traditional medical treatment? Patients whose outcomes didn't match their prognoses in ways that couldn't?" I was taken aback by the sophistication of her question. Rebecca had no medical background according to her chart it be explained by conventional medicine. Yet she was asking about phenomena that even experienced oncologists struggled to understand. The placebo effect, spontaneous remission, and psychoneuroimmunology were complex topics that most patients never encountered unless they had done extensive research into alternative healing approaches. "Rebecca, there are certainly cases where patients respond better than expected to treatment, but I want to focus on evidence-based medicine and proven therapies. Your situation is serious, and we need to act a treatment plan. What quickly to develop I want to know is whether you've been researching alternative treatments or unconventional approaches to cancer care." She smiled again, that same warm, knowing expression that seemed to suggest she understood something I didn't. "Dr. Chen, I haven't been researching treatments because I don't think traditional research will explain what's happening to me. I've been preparing for this diagnosis in other ways." This conversation was taking a direction that made me increasingly uncomfortable. As an oncologist, I deal with facts, data, statistics, and proven treatment protocols. Rebecca was suggesting something that sounded dangerously close to magical thinking, and I was concerned that she might be in denial about the severity of her condition, or susceptible to promises of miracle cures that could delay proper treatment. "Rebecca, I understand that facing multiple cancer diagnoses can lead people to explore all possible options, but I need you to understand that we're dealing with aggressive diseases that require immediate and comprehensive medical intervention. Alternative approaches should complement, not replace, proven treatments. Can you tell me specifically what you mean by preparing for this diagnosis?" Her response changed everything I thought I understood about this case, and set in motion a series of events that would challenge every assumption I had about medicine, consciousness, and the relationship between mind and body. "Dr. Chen, for the past 18 months, I've been having dreams about this conversation. Not vague dreams or feelings, but specific detailed dreams where I saw myself sitting in this exact room, talking doctor to A who looked just like you, discussing multiple cancers in my body. In these dreams, I could see the cancer cells themselves, how they were forming, where they were located, and how they were going to behave. I stared at Rebecca, unsure how to respond to what sounded like either an elaborate delusion or something that challenged everything I understood about medical diagnosis. Patients don't dream about their future cancer diagnoses with anatomical accuracy. They don't visualize cellular processes they've never studied. Yet Rebecca was describing her condition with a precision that matched our most advanced imaging technology. Rebecca, dreams can feel very real, especially when we're dealing with health concerns. Sometimes our subconscious picks up on physical symptoms before we consciously recognize them. But what you're describing sounds like more than intuition about your health. Are you saying you knew specifically where your tumors would be located? She nodded calmly. The lung tumor is in the upper lobe of my right lung, approximately 4.2 centimeters, with involvement of the pleural lining. The pancreatic tumor is in the head of the pancreas, encasing the superior mesenteric artery. The liver has 3 separate lesions, the largest being 6.8 centimeters in the right lobe. The ovarian cancer has spread to the peritoneal lining with extensive ascites formation. I felt my breath catch in my throat. Rebecca had just described her pathology with the same precision as our radiology reports. She had provided measurements, anatomical locations, and staging information that would typically require years of medical training to understand, let alone visualize in dreams. I pulled out her imaging results and compared them to what she had just told me. Every detail was accurate down to the millimeter. Rebecca, how could you possibly know these specific details? These measurements come from advanced CT scans and MRI imaging. The involvement patterns you're describing require sophisticated medical interpretation. Where did you get this information? I haven't looked at any medical reports, Dr. Chen. I told you, I've been seeing this in my dreams, but it's more my body. I can sense. I can feel the cancer cells in than just dreams nowic activity, their growth, their metabol patterns, even their genetic mutations. I know this sounds impossible, but I can actually communicate with them. This conversation had moved far beyond anything in my medical training. Rebecca was claiming abilities that violated basic principles of human knowledge of her own condition, physiology, and consciousness. Yet her was demonstrably accurate in her guess. I decide ways that seemed impossible to fake condition that we haven't discovered describing. Can you tell? You can sense your cancer cells the way you'd, to test whether her claims could be verified through objective medical evidence. Rebecca, if me something about your'd yet through our standard testing, something that would require additional imaging or laboratory work to confirm. She closed her eyes for a moment, as if listening to something only she could hear. Dr. Chen, your next round of tests will show that the pancreatic tumor has a rare genetic mutation in the BRCA2 pathway that's not typically associated with pancreatic cancer. You'll also find that my tumor markers are following an unusual pattern. Instead of the steady increase you'd expect with advancing disease, they're fluctuating in cycles that correspond to lunar phases. These were specific, testable claims that could either validate or disprove her extraordinary assertions. The genetic mutation she mentioned would require specialized testing that we hadn't yet ordered, and tumor marker patterns related to lunar cycles were not documented in any medical literature I was familiar with. I made detailed notes about her predictions and decided to order the additional tests she had suggested. Rebecca, I'm going to arrange for the genetic testing you mentioned, and will monitor your tumor markers more closely over the coming weeks. Regardless of how you're obtaining this information, we need to focus on treatment options for your condition. With multiple primary cancers, our approach will need to be comprehensive and aggressive. Dr. Chen, before we discuss treatment, I need to tell you something else about my dreams. I've seen how this illness is going to progress, and I've seen how it ends. But I've also seen something that your medical training won't prepare you for. The cancer in my body isn't just a random collection of malignant cells. It's organized, purposeful, and it's trying to teach me something. This statement pushed beyond the boundaries of what I could professionally accept, even given Rebecca's uncanny accuracy about her medical condition. Cancer cells are not conscious entities with purposes or messages. They're aberrant cellular growths caused by genetic mutations, environmental factors, and biological processes. The idea that cancer could be purposeful or communic-justative was not medically unfounded. It was potentially dangerous if it led to delayed or refused treatment. Rebecca, I understand that facing multiple cancer diagnoses can lead to searching for meaning or purpose in illness, but cancer is a biological disease process. It's caused by genetic mutations and cellular dysfunction, not by consciousness or intent. What's most important now is beginning treatment to slow the progression of your tumors and manage your symptoms. She opened her eyes and looked at me with an expression that seemed almost pitying, as if I were a child who hadn't yet learned something obvious about the world. Dr. Chen, I respect your medical training, and I know my perspective sounds impossible. But over the next few weeks, you're going to observe things about my case that don't fit within conventional medical understanding. My tumor markers will fluctuate in patterns that correlate with my emotional states and my interactions with the cancer cells themselves. More than that, you're going to find that some of my tumors begin responding to treatments before those treatments are administered. You'll document healing processes that start during our conversations, not during chemotherapy infusions. And you'll discover that my cancer cells are producing proteins and genetic expressions that shouldn't exist in human biology. These claims were so far outside medical possibility that I should have been concerned about Rebecca's mental state rather than her physical condition. Yet something about her demeanor, combined with her demonstrated knowledge of her own pathology, made me reluctant to dismiss her statements entirely. I decided to document everything she was telling me and track whether any of her predictions proved accurate. Rebecca, I'm going to schedule you for a comprehensive treatment consultation with our oncology team. We'll begin with genetic testing and expanded tumor marker analysis as you suggested. I'm also going to arrange for psychological support services, because facing multiple cancer diagnoses requires emotional as well as medical care. Can you tell me if you have family members or support systems to help you through treatment? Dr. Chen, my family is supportive, but they don't understand what's happening to me any better. Only medical team will than your. That direct, whose experienced person, who might understand, is someone communication with cancer cells themselves. That, I know sounds impossible, but in the coming weeks you're going to meet other patients who've had similar experiences. This was another specific, testable claim. Rebecca was predicting that I would encounter other patients with similar abilities or experiences. In 8 years of oncology practice, I had never met anyone who claimed to communicate with their cancer cells, and the statistical probability of encountering multiple such. Rebecca, what patients was essentially zero. You're describing would be an unprecedented phenomenon in medical literature. If other patients had similar experiences, there would be documented cases, claims. I researched studies and established protocols for investigating these have never encountered anything like what you're describing. Dr. Chen, you haven't encountered it yet, but you will, and when you do, you'll understand that medicine is about to discover something that will change how we think about consciousness, disease, and healing itself. As I left Rebecca's room that day, I found myself questioning everything I thought I knew about patient psychology and medical diagnosis. Her predictions were so specific and medically sophisticated that they seemed impossible for someone without extensive training. Yet, the accuracy of her anatomical descriptions suggested knowledge that couldn't be explained through conventional channels. Over the next week, I ordered the genetic testing Rebecca had suggested. The results arrived on a Thursday afternoon while I was reviewing treatment protocols for her case. When I opened the report, I felt a chill run down my spine. The pancreatic tumor did indeed carry a rare BRCA2 mutation that was virtually unprecedented in pancreatic adenocarcinoma. This particular genetic variant had only been documented in 17 cases worldwide, and never in combination with the specific cellular morphology that Rebecca's tumor displayed. More disturbing was the pattern emerging in her tumor marker levels. Cancer antigen 19-9, typically used to monitor pancreatic cancer progression, was fluctuating in 28-day cycles that aligned precisely with lunar phases. Her CA 125 levels for ovarian cancer showed similar cyclical patterns, while her CEA levels remained stable. This combination of markers behaving so differently within the same patient was medically inexplicable. I decided to consult with Dr. Patricia Reeves, our hospital's chief of oncology, about Rebecca's case. Dr. Reeves had 30 years of experience and had seen virtually every type of cancer presentation possible. When I presented Rebecca's case during our weekly tumor board meeting, the room fell silent. "Sarah, you're describing something that doesn't exist in medical literature," Dr. Reeves said after reviewing Rebecca's imaging and laboratory results. Multiple synchronous primary cancers with this specific distribution pattern, combined with tumor markers that fluctuate cyclically rather than progressively, suggests either laboratory error or something we haven't encountered before. I shared Rebecca's predictions about her genetic mutations and marker patterns, carefully omitting her claims about communicating with cancer cells. Even this limited information caused visible discomfort among my colleagues. Dr. Martinez, who had originally referred the case to me, looked particularly troubled. "Sarah, patients don't predict their own genetic mutations," he said quietly. "Even if she had access to medical literature, the specific variant you found wasn't documented until last year, and it's not information that would be available to the general public." How did she know to suggest that particular test? I didn't have an answer that would satisfy medical logic. Rebecca's knowledge seemed to extend beyond anything that conventional research or intuition could explain. But what happened during her second appointment made her first visit seem almost normal by comparison. Rebecca returned for her follow-up consultation on March 2nd, 3 weeks after our initial meeting. When I entered the examination room, I found her sitting in the same position as before, reading another book on meditation. But something had changed in her appearance. Despite having multiple stage 4 cancers, she looked healthier than she had during our first meeting. Her color was better, her energy seemed improved, and she had actually gained weight instead of losing it. "Good morning, Dr. Chen. I know my latest scans are ready, and I think you're going to find some interesting developments." Her tone was warm, but carried a certainty that made me uncomfortable. She was speaking as if she already knew what her test results would show. "Rebecca, your blood work does show some unexpected changes. Your tumor markers have continued their cyclical pattern, but some have actually decreased from their initial levels. This is unusual for cancers at your stage of progression. How have you been feeling since our last appointment?" "I've been feeling much better, actually. I've been having longer conversations with my cancer cells, and we've reached some agreements about how this process is going to unfold." I know that sounds strange, but some of my tumors have agreed to slow their growth while others are preparing to change their behavior entirely. The casual way she discussed negotiating with cancer cells should have alarmed me, but I was becoming increasingly focused on the objective medical evidence. Rebecca's improvement was measurable and documented, even if her explanations defied medical understanding. Rebecca, your latest CT scans show something that we need to discuss carefully. 3 of your tumors have remained stable in size, which is better than we expected. However, the pancreatic tumor has actually decreased by approximately 15%, and the tissue characteristics have changed. The radiologist noted areas that appear to be undergoing necrosis, or cell death, but not in patterns typical of treatment response or natural tumor progression. She nodded as if this information confirmed something she already knew. Dr. Chen, the pancreatic tumor was the first one to agree to begin dissolving itself. It's been the most communicative of all my cancers, and it's been showing me things about cellular regeneration that I think could be important for other patients. Rebecca, tumors don't voluntarily dissolve themselves. What you're describing sounds like treatment response, but you haven't any treatment yet. We'd scheduled your chemotherapy to begin next week. Are you taking any medications or supplements that weren't listed in your initial intake? No medications or supplements, Dr. Chen. The changes you're seeing are happening because I've learned to work with my cancer cells instead of against them. They're not my enemy anymore. They're trying to teach me something about cellular communication and consciousness that medical science doesn't understand yet. This conversation was moving into territory that made me profoundly uncomfortable. Rebecca was attributing medically significant changes in her tumor characteristics to conversations with cancer cells. As her physician, I needed to focus on evidence-based explanations for what claims about cellular we were observing, not on impossible changes are occurring. We need to proceed with your scheduled treatment consciousness. Rebecca, regardless of how these but multiple are seeing are encouraging stage 4 cancers require aggressive improvements, intervention. I don't want to delay treatment while trying to understand these unusual developments. Dr. Chen, I need to tell you something that's going to happen before our next appointment. You're going to receive a consultation request for another patient with multiple primary cancers who claims to communicate with their tumors. Her name will be Maria Santos, and she'll have pancreatic and lung cancer with genetic mutations that shouldn't exist together. This was another specific, testable prediction patient with similar experiences. Rebecca was claiming I would soon encounter another and impossible medical presentations. The was having statistical probability of such a coincidence was virtually 0, which meant either Rebecca delusions about future challenge or something happening, that fundamental events was assumptions about medical practice. Rebecca, the you're describing, would be in scenarioidence. Multiple primary cancers are extraordinary, coins rare, and patients who claim to communicate with their tumors are not documented in medical literature. If such cases existed, there would be research studies and established protocols for investigation. Dr. Chen, you're going to discover that these cases do exist, but they've been dismissed or misdiagnosed because they don't fit within conventional medical frameworks. Maria Santos are psychological, but symptoms have been her tumor markers, and imaging studies been documenting and show the same patterns you might to respond to Rebecca. As I prepare case, my claimsager buzzed with an P message from the urgent. A new patient was being department emergency admitted with multiple cancer presentations, and was specifically requesting consultation with an oncologist who had experience with unusual tumor behavior. The patient's name, according to the message, was Maria Santos. I stared at my pager, then looked at Rebecca, who was smiling with that same knowing expression I had come to associate with her impossible predictions. The coincidence was so improbable that it seemed to validate her claims about foreseeing future events. Yet accepting such validation would require abandoning everything I understood about medical diagnosis and patient-out psychology. Rebecca, I need Ford to step a moment to handle an emergency consultation. We'll continue our discussion about your treatment plan when I return. But I want you to understand that whatever is happening with your case, we cannot delay proper medical intervention based on unconventional theories about cancer behavior. Dr. Chen, when you meet Maria Santos, ask her about the dreams she's been having. Ask her if she can describe the genetic mutations in her tumors before you run the tests. And ask her if her cancer cells have been showing her things about other patients in the hospital. I left Rebecca's room with a mixture of professional skepticism and growing unease. Everything she had predicted about her own case had proven accurate, from genetic mutations to tumor marker patterns. If Maria Santos confirmed Rebecca's latest prediction, I would be facing evidence that challenged the very foundations of medical science and human consciousness. As I walked toward the emergency department, I found myself hoping that this new consultation would be routine, that Rebecca's prediction would prove wrong, and that I could return to treating cancer with the evidence-based protocols I understood. But as I approached the emergency department, I had a sinking feeling that my understanding of oncology, and perhaps medicine itself, was about to change forever. I found Maria Santos lying in bed 12 of the emergency department, her dark eyes fixed on the ceiling with an expression of profound concentration. She was a 41-year-old architect from the city's east side, and according to the intake notes, she had been brought in by her sister after experiencing severe abdominal pain and difficulty breathing. Her preliminary scans showed masses in both her pancreas and lungs, but what made her case immediately unusual was her insistence on speaking to a doctor who understood tumor consciousness. When I introduced myself, Maria's response was almost identical to Rebecca's calm acceptance. She looked at me with recognition, as if we had met before, and spoke with a certainty that seemed impossible given her recent diagnosis. "Dr. Chen, I've been expecting you. I know this sounds strange, but I've seen you in my dreams for the past 2 months. You were discussing my case with another woman who has multiple cancers, someone who taught you to listen differently to what tumors are trying to communicate." The parallel to Rebecca's predictions was so precise that I felt a chill of recognition. Here was another patient claiming prophetic dreams, another case of multiple primary cancers, another person discussing tumor communication as if it were a normal aspect of medical care. I decided to test Maria's knowledge in the same way I had tested Rebecca's. "Maria, you mentioned seeing me in dreams. Can you tell me anything specific about your medical condition that we haven't discovered yet through our standard testing procedures?" She closed her eyes briefly, adopting the same listening posture that Rebecca had used during her consultations. "Dr. Chen, my pancreatic tumor carries a combination of genetic mutations that shouldn't exist in nature. You'll find KRAS G12D mutation combined with a BRCA1 variant that's typically only seen in ovarian cancer. The lung tumor has a different genetic signature entirely, with an EGFR mutation that's responding to cellular signals from the pancreatic mass. These were extraordinarily specific molecular details that would require specialized genetic sequencing to confirm. More importantly, Maria was describing cross-communication between tumors in different organs, a phenomenon that had no basis in established cancer biology. Tumors don't coordinate with each other across organ systems, yet Maria was describing her cancers as if they were part of a unified biological network. "Maria, the genetic combinations you're describing aren't documented in medical literature. Tumors with those specific mutations don't typically occur together, and cancer cells in different organs don't communicate with each other. How do you know these molecular details about your condition?" "Dr. Chen, I know because I can hear them talking to each other. Every night for the past 8 weeks, I've been listening to conversations between my cancer cells. They're not random growths, they're organized, purposeful, and they're part of something larger that's happening to people like me and Rebecca." The fact that Maria knew Rebecca's name without any introduction from me confirmed that something extraordinary was occurring. These 2 patients, who had never met and came from different parts of the state, were somehow connected through their experiences with cancer consciousness. I needed to understand the scope of what I was encountering. "Maria, you mentioned Rebecca by name. Have you ever met her or had any contact with her outside of your dreams? No direct contact, Dr. Chen. But in the dreams, I see her clearly. I watch her conversations with you and I learn from how she explains her relationship with her cancer cells. She's further along in the process than I am. Her tumors have been teaching her for almost 2 years, while mine only started communicating recently. This information aligned perfectly with Rebecca's timeline. She had mentioned 18 months of dreams about her diagnosis, which corresponded to Maria's claim that Rebecca was more advanced in whatever process they were both experiencing. Documenting coins was identities that seemed to violate basic principles of probability and patient psychology. Maria, I'm going to order the genetic testing you've described. In the meantime, I need to understand more about these dreams you're having. Can you tell me other details about future medical events that we could verify? That's where Rebecca's case ends, and my medical career took a different path. Maria Santos confirmed every prediction Rebecca had made, down to genetic mutations that shouldn't exist, and tumor behaviors that defied everything we understood about cancer biology. Both patients eventually achieved complete remission through mechanisms that medical science still cannot explain. I left oncology 6 months later, not because I lost faith in medicine, but because I realized there are aspects of healing and consciousness that our current understanding cannot encompass. Rebecca and Maria taught me that sometimes the most profound medical mysteries aren't meant to be solved, but to humble us and expand our definition of what's possible. Their cases remain open files in our hospital's records, unexplained but undeniably real, challenging every assumption about the relationship between mind, body, and the nature of disease itself.